Next on the docket is osteoporosis, and so go ahead and turn in your books to page 1553. Okay, osteoporosis is known as porous bone disease, and when you're looking in your book, if you go to page 1554, you can see the risk factors for osteoporosis. For instance, aging, females have a higher incidence, lower body weights, whites, you smoke cigarettes, a non-traumatic fracture, sedentary lifestyle, etc. So we need to look at these risk factors because some of them are modifiable versus non-modifiable. What we know is that bone formation is equal to bone reabsorption for the typical adult at about the age of 35. And then after the age of 35, the bone reabsorption tends to exceed new bone formation, and then we start to develop osteoporosis because it is a natural aging process. So this is when we really need to encourage modifying the modifiable risk factors as outlined on page 1554. What we know is that only 1 out of 8 men have it, but half of all women have it. And of those women that do have osteoporosis, 1 out of 2 will at some point in their life experience a fracture due to their osteoporosis. As far as diagnostics go, bone mineral density scans or DEXA scans are the most accurate way. X-rays just don't pick it up quick enough, and so we actually need to do DEXA scans. DEXA scans are non-invasive tests. They don't hurt. They're relatively inexpensive now and provide accurate information so individuals can choose if they need to have therapy or not. So we diagnose it by looking at the risk factors, getting a history, measure the bone density, and sometimes there's other labs that might need to be drawn. We want to prevent further bone loss. When we do this, we can decrease the risk of someone having a fracture. A lot of times we do need to place individuals on medications, and medications either do one of 2 things. They decrease bone reabsorption or increase new bone formation. But overall, we need to encourage individuals to eat a diet that's high in calcium, to take their medications, to practice weight-bearing exercises, and hopefully to prevent falls and fractures. So here are some of the foods that are high in calcium, but also on page 1555 in your book, there is a really good nutritional guide that shows you foods that are high in calcium and then things that are low in calcium, so you can share this information with your patients. All right, so on page 1556, it talks a little bit about the drugs that we might give for someone who has osteoporosis. First, it reminds us that estrogen is not a good idea anymore. And the reason is because it increases heart disease, breast cancer, etc. in women. And so gold standard now are the biophosphonates. What you'll notice about the biophosphonates is that they end in the dronate, and so that kind of helps to identify them. But the biophosphonates can have some bad GI effects, and so that's why we make sure that patients know that they need to take these with a full glass of water, take food 30 minutes prior to taking it, and remain upright for at least 30 minutes when they do take it. One of the worst side effects is what they call jaw osteonecrosis, which is just bone death of the jaw, and this is very rare though. Then we go on and talks about calcitonin. Calcitonin, which comes in calcimar, is either an IM injection, sub-Q injection, or nasal form. It also has some bad GI side effects, and so they essentially tell people to usually take this at night and remind people if they're using the nasal form to alternate the nares. And then it does mention the SERMs. The SERMs are your selective estrogen receptor modulators, so they mimic the effects of estrogen, and so they actually help with bone reabsorption. So bone reabsorption are the SERMs, and those are the only drugs that we're going to learn for osteoporosis. So when we're talking about the care of someone who has osteoporosis, we really need to encourage a few things. We need them to focus on proper nutrition. We need them to specifically focus on getting enough calcium, or even if they need to take calcium supplementation. And so there's a great chart on page 1556 that kind of shows you the different milligrams in each of the different calcium supplements that are available to people. They need to also exercise, but it's weight-bearing exercise. You need to have that impact or that stress on the bones. So for instance, this is not good. This is when swimming in like water aerobics are not good. And then we want to encourage them to do things around their house that would prevent them from falling and developing a fracture. Get rid of the throw rugs. Make sure you have proper lighting. Make sure you have in your bathroom anti-slip mats. Those types of things that you guys learned in fundamentals. And we want to make sure that these guys understand how to take their medications and that they're going to need to have follow-up DEXA scans. Your book goes on to talk about the fact that adequate calcium intake for a premenopausal woman is about 1,000 milligrams a day, but for a postmenopausal woman, it is up to 1,500 milligrams per day. And so for pre, 1,000, and post, 1,500. And it reminds us that vitamin D is important in order to absorb the calcium, and so it can function properly within our bones. And so sometimes women also need to take a vitamin D supplement. Just going to talk briefly about Paget's disease. This is on page 1557 in your book. Really, it's kind of a form of osteoporosis. This person has a chronic skeletal bone disorder. They have excessive bone reabsorption, but it is followed by irregular bone repair and formation. Not really sure why people get it. Signs and symptoms: bone pain. Sometimes it's diagnosed accidentally, and they end up with bowing of the legs, issues with the spinal cord, fractures, and skull pain. Sometimes what can happen is they can develop what's called platybasia, where they have actual flattening at the base of the skull, and then it could lead to an obstructive hydrocephalus or brainstem compression. Diagnose it with history, exam, DEXA scan, x-rays, and labs. And really the goal is to just relieve the pain, prevent fractures and deformity. You'll see that the treatment is very similar to osteoporosis. We prescribed analgesics for the pain. A lot of times NSAIDs. NSAIDs are very good for bone pain. Steroid injections. The bisphosphonates, just like for osteoporosis, and calcitonin. Physical therapy to help with the different deformities that they get of their lower legs. Surgeries a lot of times can repair or straighten the legs, and weight-bearing exercise.